Tie. Light off. Okay. Better? Okay. Okay. So this is a slit lamp photograph taken of her right eye. Her left eye looked normal, and the anterior chamber depth was approximately equal in both eyes. So the first question for 3 marks, so we're looking for 3 things, is what's your immediate management of this patient? Okay, the second question of this question is, what other 2 things would you do on your examination? And there could be more than 2 things, but if you mention at least 2 of them, then that's what we're looking for. Okay, part C is what other management could you do? If the pressure is not responding, what other things could you do? So we're looking for 2 things. There are more than 2 things that you could put down, but we're looking for 2 things that you could do if the pressure is still not responding. Okay, and D is what would be your management prior to discharge? Is there any other thing you would do before the patient was able to go home? And the last part, this is actually E. Can you name 2 grading systems for classifying angles? 2 grading systems for classifying angles. Okay, question 2. These are 5 different glaucoma drops. These are the brand names of 5 drops used in the glaucoma clinic. Can you give me the generic name and the concentration of these drops? So 1 mark for the generic name, 1 mark for concentration. Okay, question 3. So have a look at this gonioscopic appearance. Okay, and you can see the arrow points to a certain feature which is shown here. Okay, so the question is, what condition does this most likely represent? So I'm not asking what the feature called, but what condition is it most likely to represent?
Just one question.
No, I'm coming on to the rest. Okay, and the second B, who first described this condition? That's just to check if you attended the grand rounds, given this talk a couple of times on pseudo exfoliation. Who described the condition? C, in patients with this condition, that feature is most likely to represent, give 2 causes of visual loss or visual decline. Give 2 features which might cause difficulty during cataract surgery. What 2 features in patients with this condition might cause difficulty during cataract surgery? Part E, can you tell me what the gene is associated with this condition? And last part, well, actually one more. We got one more part actually. Part F, can you give me what the risk of glaucoma is in these patients? It's approximate. I mean, there are lots of studies being done with varying risks, but what's the risk of glaucoma classically? And last part, the picture I showed you at the beginning, can you give me one other cause of this kind of appearance? One other cause of this kind of appearance. What other condition might cause a similar appearance on gonioscopy? Of the feature pointed out by the arrow. A question, okay. Okay, question 4. This is a test you commonly see in the glaucoma clinic here. So have a look at it, and you can see these colored lines. Over here you can see some writing over here. Okay, you can see these colored lines, and you can see various symbols designated to these colored lines. So I'll come back to this again, but I'll move on to the question. So the part A is, what do 1, 3, and 5 mean in Roman numerals? So what does this 5, 3, and 1, what does that indicate? Part B, what does 3E and 4E mean? So we've got 4E here, 3E here. Just in general, 3E, 4E, what does that represent? I don't need an exact value for it, just in general terms, what is it? Okay, what do the terms fix and resp mean that the person doing the test has indicated up here? What does this mean? What does fix and resp? What do those two terms mean? What are the colored lines called on this test? What's the name given to the colored lines? Okay. Part E, give me 3 reasons why you might perform this test rather than automated perimetry. What are the reasons performing kinetic perimetry rather than automated perimetry? Now, the ophthalmologist who invented this test, can you give me 2 other things he invented? Okay, so we move on to question 5. This is the last question. Huh? Okay, this is the last question. So these are 5 surgical instruments seen in the glaucoma operating room. Okay. For each of them, can you please tell me, number 1, what is the instrument called? Okay. And number 2, what is it used for? So 2 parts to each, A, B, C, D, E. What is the instrument called? And what is it used for? And I want the exact name. Yes. Okay, all done? If there's any way to enlarge it. Don't know if that's any clearer, but okay, are we finished? What do you do now? Swap papers or what? Repeat them again. Okay, so just to recap, question 1 was a 70-year-old lady with pain in the right eye for 1 day, reduced vision, pressure of 54, and disappearance. Part A, what is the immediate management of this patient? Give 2 other findings you would look for on your examination. What other things could you do if the patient is not responding to treatment, initial treatment? What should you do before the patient goes home? What treatment should you do before the patient goes home? And this is actually E. Name 2 grading methods for classifying angles. Question 2 was this question about drops. These are the brand names. Give the generic name and the concentration. Question 3 was about this feature on gonioscopy. What condition is this likely to represent? Who described the condition? Give 2 causes of visual loss or visual decline in patients with this condition. What features give problems during cataract surgery? Give the associated gene. What's the approximate risk of glaucoma? And give 1 other cause of that sign seen on gonioscopy. What other conditions can cause it? Question 4 was about this. Yeah. What do 1, 3, and 5 mean in Roman numerals? What do 3 and 4E represent? What does fix and resp mean. What's the name given to the colored lines? Give 3 reasons for performing kinetic perimetry rather than automated perimetry. And give 2 other inventions by this ophthalmologist who invented this test. Okay, so ready for the answers, or do you have a break and then go through the answers? Go through the answers? Oh. So do you swap papers, or what do you do? I don't know. Okay, so question 1. Huh?
You need to collect the papers.
I need to collect them.
Yeah. Unless you're going to give us all full marks.
I'm sure you'll all get full marks anyway, to be honest. Okay, don't worry. Do I have to mark them? Or who marks them?
Give everyone again full marks. Just don't have to think about it.
Good idea, good idea. All 0. Fair? Okay. Oh, thanks. Okay, so let's just go through the answers quickly, and then we can go and pray. Thank you. So immediate management of angle closure, acute glaucoma, which is what this is. Topical, alpha agonist, iopidine or alpha-GAN. Topical beta blocker if there's no contraindication. Oral or intravenous Diamox. Lie the patient supine is a reasonable suggestion that can help the lens iris diaphragm fall backwards, and it can help open up the angle. Topical pilocarpine is usually not in the immediate management because the iris is ischemic and it doesn't work. But if you say, I'd give it after the first half an hour or something like that, then that's acceptable. Two other examination findings. The most important examination finding is gonioscopy. Okay, and you often can't do gonioscopy on the affected eye because the cornea is cloudy. So do gonioscopy on the fellow eye. Particularly if they have similar depth anterior chambers, if the fellow eye is occludable, then the eye that they're presented with is likely to be occludable as well. Optic disc exam if you can, because obviously if a patient presents with a pressure of 50 and they've got advanced disc cupping, they're going to lose vision much more quickly than a patient who has 0.3 disc might be able to tolerate a higher pressure for a bit longer. And fundal examination. So these are, three answers. I'd accept any two of them. Or even if you put B scan, that's reasonable. Other management if patient is not responding. So if the pressure is not coming down after a couple of hours, you could try any of these measures. You could repeat the steps in part one. Okay, so you could repeat the beta blocker, iopidine, Diamox, and so on, pilocarpine. You could try corneal indentation to try and force the angle open, re-divert the aqueous. You could get intravenous mannitol if there's no contraindication. Or you could do an emergency iridoplasty. Okay, so these are all things you can try to break a refractory attack of angle closure. The thing you must do before the patient goes is laser PIs, and I'm sure you all know that from your casualty training. There's three other methods for grading angles, so I'd accept any two of the ones given here. Schaefer, which is the most commonly used, space classification, which is the A, B, C, D, E with the number, or Shy grading. Van Herrick's not really an angle grading. Okay, that's a grading of anterior chamber depth. Okay, so these are the names and concentration of the drops. For alpha-GAN, I would accept 0.15 as well as 0.2. Zoller and Trusopt are essentially the same thing. Zoller is just locally manufactured. Any questions on that one? Okay, so the most common cause of this line, which is Sampolesi's line, is pseudoexfoliation. Okay, so if you put pseudoexfoliation or exfoliative glaucoma or pseudoexfoliative glaucoma, those are all correct. I'd accept that. Who described this condition? It was a Finnish ophthalmologist called John Lindberg, and I mentioned that in my pseudoexfoliation talk. Two causes of visual decline in these patients, glaucoma, and they're more prone to get nucleosclerotic cataract. So we know from like the Blue Mountain study and large epidemiological studies that the incidence in age-matched people with pseudoexfoliation of nucleosclerotic cataract is almost twice as high. Okay, cataract surgery is difficult because the pupil doesn't dilate and because of zonular laxity. Okay, and you could have put sticky cortex. There's some speculation that the cortex might be more sticky in exfoliation, so I'd accept that as well. Giant capsule. Fragile, yeah, okay. Sorry? risk of glaucoma during cataract surgery? Oh, yes. Okay, there's no answer. Yeah, 50% is acceptable. In fact, if you give anything between 10 and 50%, I'd accept it because the estimates in the literature are so variable. But classically, it's 40 to 50%. Okay, other things can give rise to a pigmented line anterior to Schwalbe's line. Pigment dispersion is probably the next commonest. Trauma, uveitis, and iris melanoma are other causes. Yeah, go ahead. Yes. Anything between 10 and 50% I'll accept. Yeah, because I presented a few figures a couple of weeks ago, and the studies are very variable on this, but classically it's 50%. So I'm sure you all know about Goldman visual fields in detail, and you're all experts at this, especially Ibrahim Obeida, who's worked with me. So 1, 3, and 5 in Roman numerals, these are the stimulus sizes, okay? Size 3 is the standard stimulus size that we use the Humphrey visual field, and that's 0.43 degrees in diameter. Okay? Size 2 is half of that stimulus size, and size 1 is half still. So as you double the stimulus size, you increase the area by 4. 3E and 4E represent stimulus intensities. Fix means fixation, okay, and rest means responses. So the perimetrist will say, was the fixation accurate when he looks at the eye through the scope? Was the fixation accurate? And what were the responses like? Was the patient a bit unsure at times? So the responses, were they brisk? Were they slow? Were they, unreliable? So that's what those two mean. So, there are markers of reliability for Goldman visual fields. Colored lines are called isopters. Okay, so an isopter is a line joining locations of equal sensitivity. When might you do a Goldman visual field or kinetic perimetry? Here, the commonest reason is poor visual acuity. Okay, if they have an consistently unreliable Humphrey visual field test, that's a good enough reason. You might want to get a wider visual field because the Humphrey visual field only measures out to 30 degrees. So if you want to measure neurological fields, you might want to get a Goldman visual field for that reason. And the last reason I put here, if you want to confirm the defect on Humphrey, okay? So if you weren't sure and you want to do Goldman to confirm. So, Hans Goldman is a very interesting chap, and he had an obituary published a few years ago, which was translated into English. And, it's worth reading because he really did a lot for ophthalmology. So, just think if we didn't have, his inventions in the clinic, which are still being used today just as frequently. So, Goldman three-way mirror and applanation tonometry, he was instrumental in designing. Okay, so Stevens muscle hook. Same as squint for squint surgery, we use it for hooking muscles during tube insertion. Curved Stevens scissors, because they are straight curved Stevens scissors as well. And we use that for conjunctival dissection or creating a conjunctival pocket. Tube forceps are used to insert the tube into the eye after you've made a sclerostomy. Dewecker iridectomy scissors, used for making an iridectomy during trabeculectomy. And Colibri forceps are used for grabbing tissue, in particular iris, during the iridectomy. Okay, any questions on that one? So should we have a 10-minute break and then we'll do the last lecture quickly and then we can go? Okay. What happened to your eye? What happened to your eye? What are you doing here?
Yeah, just
Oh, you're not working. Okay.
this is a severe.
Very bad. Your other eye was affected or not?
No,
Oh, not yet.
yeah, but a lot of.
Oh, yeah, a lot of too many.
Yeah, I think it's necessary. But it's very, it will be very difficult for you that's why I told you it's very
You let all be ready by Thursday or Friday.
to be here.
We start? Okay. Okay, so we'll just start because it's getting late now. So I'm going to talk a bit about glaucoma imaging, and we're in an exciting time at the moment where OCT imaging is superseding all other modalities. But I feel it's worthwhile knowing about other imaging technologies in glaucoma, particularly the ones that we were using prior to Fourier domain OCT, and it's useful to know because you should be aware of the different technologies, and it's something that might even come up in an MCQ question in the exam. I did a European Board of Ophthalmology exam in glaucoma a year ago, and they asked me about different technologies like HRT, scanning laser ophthalmoscope, scanning laser polarimetry, and how these worked. So I think if you have an idea about them, I think it's a good idea. So, in glaucoma, we're trying to document the structure, or do a structural assessment and document the results of optic nerve head assessment and retinal nerve fiber layer. And it's an integral part of our assessment of glaucoma patients. In particular, in looking at the optic disc, we're interested in disc size and also quantify the amount of neuroretinal rim tissue. And that's particularly how these devices help us, is to provide an estimate of the amount of rim tissue and whether this rim tissue is normal or not. And when we also assess the nerve fiber layer, and these are two pictures taken. The first one in a normal individual, and what we can see is retinal nerve fiber layer striations, and these striations are visible on red-free light, and more obvious in younger individuals. And the striations are thickest around the blood vessels, and they follow the pattern of rim thickness. So retinal nerve fiber layer is thickest at the superior and inferior poles, and thinner temporally. And the second picture shows two wedge defects, one superiorly and one inferiorly, in a patient with glaucoma. And you can see that the disc is cupped in this patient, about 0.8 cup to disc ratio. And you'd expect this patient probably to have some visual field defect. Can everyone see those wedge defects? Yeah. So when you're looking for nerve fiber layer defects, you're looking for something that's missing rather than something that's there. Okay, because it can be quite difficult to spot when you start looking for nerve fiber layer defects. Unfortunately, the science of looking for nerve fiber layer defects in this population is gone, because we see patients with 1.0 cups already, so we're not looking for those early signs that we look for elsewhere. But if you get patients with glaucoma suspects, it's worth dilating them and just see if you can see any nerve fiber layer defects, even just for practice. So methods for imaging the optic nerve head are just by ophthalmoscopy and making a drawing of the nerve. You can take a photograph, and a photograph is a very way of still documenting the optic nerve. And what I'm going to talk about in this lecture is really specialized imaging we can use to optic nerve head and retinal fiber. One of these methods is scanning laser ophthalmoscopy, and the most commonly used was HRT, Heidelberg Retinal Tomograph, manufactured by a company in Germany. And this is still used in quite a lot of practices in the West. So this is what the HRT looks like. And it has a small field of view, 15 degrees by 3 degrees, and it utilizes a diode laser. And the light source is monochromatic, and it illuminates one spot at a time of the retina to build up a picture, and the reflected light from the retina is picked up by a detector. And this is the machine as it looks like in the clinic, and you can see that the HRT is linked up to a PC, which then gives a report of the image. So the essential components of a scanning laser ophthalmoscope, or HRT, is a laser, a beam splitter, and a detector. So what the laser does is to shine light into the eye or the object of interest. The light is then reflected and via a beam splitter enters a detector. And depending on the amount of light reaching the detector, an illuminance image is formed for a particular spot, and by scanning multiple spots individually, you can get an image of the entire 15 by 15 degree plane. Now, any light that is outside the object of interest gets blocked by this diaphragm and doesn't enter the detector. So the HRT provides XY images over a range of focus or Z planes. So it is able to form a 3D image of the optic nerve head. And it takes 3 images quite quickly. Within about 2 seconds, you can get 3 3D images of the optic nerve head. And the reason for taking 3 is that you can take an average of the 3, and that reduces variability. And also, apart from taking an average to increase accuracy, it can also measure, how variable is the image. Because if you have 3 measurements, you can work out the standard deviation of those images, and you can say, well, this is the standard deviation we expect if we test the same patient again. So if a patient is progressing, you expect variability greater than that standard deviation. Okay? So it takes a range of images for a depth of planes, and so we obtain, a number of XY images, which can then be put together in a 3-dimensional view. Now, the HRT3 gives a number of image quality checks, and this was an improvement on the HRT2, and in particular, checks regarding image brightness and illumination and eye drift. So these are all things we can use to judge the quality of the image. The most important one of these is actually mean standard deviation, or sometimes called mean pixel height standard deviation. And that's a value, between 1 and 100 microns. And what that tells us is how variable, what's the variability in the image. And we're really looking for values of, between 20 and 30 for a good image. Above 50 means you've got quite a poor image. What things can be done to improve the quality of the images? Well, pupil dilatation can help, particularly if it's myosed pupil, patient's been on pilocarpine, or if the patient has lens opacity, then dilating can help. But usually in a 3mm pupil, you can get a reasonable image. The images can be checked for excessive eye movement and blinks, and the software can help you with that. And you can take several scans, if the images take not very long to acquire, so if you're not happy with the first image, you can take several images to decide on the best one. And like I said, the best indicator of scan quality is this mean pixel height standard deviation, which tells us how variable the image quality is. And the HRT3 gave various improvements to provide feedback on the quality of the image, and particularly to tell us whether the focus, illumination, and whether the centering was adequate. So this is the report given by the HRT3, and what we can see is a mean topography image, a reflectivity image, and also an interactive display. And as you move the cursor, the interactive display also moves depending on the plane of that's being looked at. Now, one of the things about the HRT is it required you to draw a contour line. So you had to delineate where you think the margin of the optic disc is. So you can imagine this is a source of variability. If I go and draw the disc margin, or if Saad goes and draws the disc margin, we might get 2 different answers. And that will give rise to different rim area measurement. Okay? So that was one of the criticisms of this device, is that it was highly dependent on contour placement. And what you're aiming to do with your contour line is delineate the outer margin of the rim, okay? Not the scleral ring, okay, which if you get a bit of papillary atrophy, you can actually overestimate the rim area. So we have an image which is at various depths. So how does the software decide which is going to be cup and which is going to be rim? Well, what it does is to place a reference plane 50 microns below the retinal surface. Okay, then any measurements taken above that plane are rim, and any measurements below that plane is cup. So structures that lie within the contour line and above the reference plane are denoted as neuroretinal rim, and any space below the reference plane is denoted as optic disc cup. Now, this is the report that we get printed out from the HRT, and what we see here is the green is the contour line, okay, and these crosses and ticks indicate whether the measurements are within a statistically normal range. Okay, so original HRT had about 100 normals in their database. So when you take a measurement of a patient, it will compare the rim area for that patient with the normals in your database and say, is it within 95% confidence interval for normality or not? Okay, so it doesn't tell you whether the patient has glaucoma. That's the clinician's decision. Okay, but what it tells you is it's statistically likely to be normal or not. So how does the HRT decide whether something is normal or not, whether a disc is normal or not? There are two main methods, broadly speaking. The first method is contour line dependent algorithms. So when you draw a contour line, it will measure the rim area in 6 sectors and tell you how that rim area compares to your normal database. The second method are contour line independent methods, and this is something called a glaucoma probability score. So rather than looking at rim area, what it does is analyzes the shape of the cup and says, well, how likely is this shape likely to be normal or not? Now, because the contour line method, the main contour line method is Moorfield regression analysis, and because I trained there, I should just give it a mention. So the Moorfield regression analysis, what it does is assesses the rim area measurements. Now, how does it decide whether the rim area is normal? So these are measurements for 6 sectors, and it uses 2 different relationships. The Moorfield regression analysis uses 2 relationships in normal eyes. So we know what happens to the size what happens to the rim area as disc size gets bigger. So if you've got, say, a 0.6 cup in a small disc, and you've got 0.6 cup in a large disc, okay, as the disc gets larger, what happens to the rim area? Gets larger. So this graph, that's what it's showing, is the relationship between rim area and disc size. Okay, so as disc size gets bigger, rim area gets bigger. And what do you think happens to the rim area with age? Decreases, yeah? So some people have described glaucoma as accelerated aging, because with age, you lose nerve fiber layer, you lose axons, and you lose rim area. Okay, so there's a normal age-related loss. Even if you take a normal individual and look at their nerve over time, they will lose rim area over time. So we know there's a relationship, even in normals, between rim area with optic disc size and age. So the Moorfield regression analysis uses this relationship to estimate what the rim area should be for a person of a given age and a disc size. All right? And then it estimates that, and it compares the rim area that you measure. And it says, well, how does this rim area compare to the estimated rim area? Now, so we talked about Moorfield regression analysis, which is a contour line dependent method. And this is a contour line independent method, which is glaucoma probability score. And what the glaucoma probability score looked at was the shape of the cup. Now, as the retinal nerve fiber layer surface becomes flatter. The more advanced the glaucoma, the surface of the nerve fiber layer becomes more flatter around the optic disc. And the cup becomes larger, it becomes steeper, and it becomes deeper. So we know that eyes with glaucoma tend to have a certain shape cup compared to normal eyes. Okay? And these can be modeled by probability density functions. So if you've got a certain cup in a given patient, you can say, well, how likely is it to be glaucoma or normal? So, glaucoma probability score, GPS, uses size, the depth of the cup, and the steepness to gauge the likelihood of normality. And like the Moorfield regression analysis, it assigns a tick, exclamation mark, or cross. Tick means it's within normal limits. Cross means it's outside 95% confidence limits. And exclamation mark means it's borderline or between 90 and 95% limits. So this is a GPS classification for a given eye, and you can see the cup looks quite small, about 0.4, 0.5, and each of the sectors have a tick beside it indicating that, according to GPS, this is likely to be a normal nerve. This is an abnormal nerve. Okay, the rim area is abnormal, or the rim is an abnormal shape in each of the sectors. And what's interesting is, if you take this abnormal nerve and look at it with Moorfield's regression analysis, it comes out normal. Okay, so using different algorithms, even for the same nerve, could have given different answers. So we talked about contour line image analysis and systems available without a contour line. And it's the same for looking at progression. Okay, so if you want to look at rim area change over time, there you can look at how the rim area changes over time, looking at Moorfield regression analysis rim area, or you can look at TCA, which is another method which I'll talk about. So this is a patient who has rim area measurements over time, and you can see that over the space of about 7 years, the patient developed a nasal step. Okay, and on the HRT longitudinal analysis, you can see there is loss of particularly temporal inferior rim tissue over time. Okay, so inferior rim tissue fits with a nasal step. Now the TCA is another method that compares, that looks at change over time, and what it does is compare local change in retinal height between the baseline image and follow-up images. So this is a TCA analysis, and what you can see up here is a baseline image. Okay, these are subsequent follow-up exam images. Okay, at the bottom here, the clusters in red are areas that are changing. Okay, so you can see the rim appears to be changing. The middle row indicates red only if the rim area change is greater than the variability that you'd expect, the test-retest variability. So, like we talked about, if you take 3 images, it'll give you an estimate of variability within the images. And if the change is greater than the variability, then it's marked as change in the middle row. So that's the one we tend to look at. Okay, so HRT had a number of limitations. The first one is that you needed to draw the contour line, so that was a major source of variability. And the classifications that were available, particularly the Moorfield regression analysis, for big disk sizes, the Moorfield regression analysis had low sensitivity for large disks. There are lots of strengths about the HRT. It's been around a long time, so we have a lot of data on it. The progression algorithms are very well developed. one of the criticisms for the original normative database was all white Caucasians. Okay, so if you have normal data for white Caucasians and you scan an African American, they might be normal, but it comes up as abnormal on the output because you haven't got any African Americans in your normative data set who might have larger discs. So the newest generation of HRT included race-specific data, and it gives you some quality control feedback during acquisition. So just a bit about, so I've finished with the scanning laser ophthalmoscope. I'm going to talk about the scanning laser polarimetry now, or GDX. Has anyone heard of the GDX? So what the GDX does, or the scanning laser polarimeter, the GDX is a scanning laser polarimeter produced by Carl Zeiss, and it assesses the peripapillary retinal nerve fiber layer using a diode light source. And it measures birefringence. And just to remind you, birefringence is propagation of light which depends on polarization of light. And when light passes through a birefringent medium, it changes speed. Okay? And that change of speed is called retardation. Okay, so in the eye, the retinal nerve fiber layer is a birefringent structure. When you shine polarized light through it, it undergoes retardation, and that retardation is proportional to the thickness of the nerve fiber layer. So by measuring retardation, you can get an estimate, or the machine gives an estimate of the thickness of the nerve fiber layer. So, light is shone through a polarizer, which makes light unidirectional, and then passes through the birefringent structure, in this case the retinal nerve fiber layer, and then we're able to measure retardation. And by measuring retardation, we can get an estimate of the thickness of the nerve fiber layer. The thickness of the nerve fiber layer is correlated to the amount of retardation of light. Now, although the RNFL is the most birefringent structure, the problem is there are other birefringent structures in the eye. Okay? And most importantly, the cornea is a birefringent structure. So if you measure birefringence from the eye, you'll not only be measuring retinal nerve fiber layer birefringence, you'll be measuring corneal birefringence as well. So in order to minimize this, the GDX, VCC, and ECC included software which were able to cancel out the effect of corneal birefringence. So this is what the machine looked like. And it had an algorithm which compensated for corneal birefringence. So this is a retardation map from the GDX VCC. And what we can see is this color-coded, and the warmer colors represent areas of high retardation or high nerve fiber layer thickness. And as we'd expect, the nerve fiber layer is thicker at the poles compared to elsewhere. So what you were required to do when you took an image is take an image of the macula first of all. Okay, and the image of the macula, the machine used that to estimate corneal birefringence. And then you take an image of the nerve fiber layer, and from that it subtracts the corneal birefringence from the first macular scan to give you the residual nerve fiber layer thickness. So this is a typical printout from the GDX VCC, and there was a newer generation called ECC with better corneal birefringence capabilities, and it gave a number of different parameters, including nerve fiber layer thickness. Consistently in studies, the one that was most sensitive for distinguishing glaucoma from normal eyes was the nerve fiber layer index, NFI, and this was a value between 1 and 100, and the higher the score, the more likely the eye is to be glaucomatous. In healthy eyes, the NFI is usually below 35. And the output gives us a deviation map, and what that deviation map is, it compares the retardation image with an age-matched normal database and says how far are these values from healthy age-matched controls. So areas in red here means that the areas are likely to be thin nerve fiber layer. And we also get a contour map similar to what we see in the OCT, otherwise known as the T-SNIT curve. Now the main problem with the GDX VCC was that if you had patients who had atypical corneal birefringence, then it performed badly. And this main reason people stopped using this device is that in a large proportion of patients it would come out abnormal, even in healthy eyes. And particularly in myopic eyes, lightly pigmented fundi, and elderly subjects, it seemed to perform badly. They did improve on the GDX VCC with the ECC, which was enhanced corneal compensation. And what you can see there is the RNFL profile in a patient with glaucoma, and you can see the VCC gives these two artifactual spikes on the temporal sector of the nerve fiber layer, which are eliminated with the use of the ECC device. So I think all you have to know about the GDX is that it measures thickness based on retardation of light. It can be compared to a normal database. And there were no progression algorithms in the GDX, so you could only use it for cross-sectional analysis. So I've got another talk on OCT, which I'll give at a future imaging meeting, but just to briefly mention about OCT, because it superseded these other devices. So we know it's a non-contact method, gives us a cross-section of the retina and optic nerve. It uses low coherence interferometry, and when the light waves interfere with one another, it produces an interference pattern. It's based on the principle of Michelson's interferometry, and it is able to capture high-resolution images of the retina. So, here we have, this is the original design in OCT 2 and 3, and it contains a beam splitter which splits light into two arms. One goes up to a reference mirror and one goes through the tissue of interest. Those two rays then interfere, producing an interference pattern, and based on that interference pattern, the thickness of the tissues can be estimated. Now, just like ultrasound, OCT can be done as A scan or B scan. A scan just gives us one-dimensional information, and B scan gives us two-dimensional information. And as a reminder, what we're interested in glaucoma is the inner retinal layers next to the vitreous here, so the nerve fiber layer and the ganglion cell layer, and also the inner plexiform layer. And these areas become thin in advanced glaucoma. The OCT image is color-coded. Okay, the warmer colors represent, red and white represent signal of high intensity, highly reflective areas, and blue and black colors represent less reflective tissue. And here we can see an OCT image with the layers. So we have the internal limiting membrane next to the vitreous, and then retinal nerve fiber layer, then the ganglion cell layer, and the inner plexiform layers. And these are the layers that we're interested in glaucoma. Most OCT machines will do a peripapillary scan, and this in the original Stratus OCT3 was a 3.4 millimeter scan. So what it does is to scan the just outside the circumference of the optic nerve. The scan starts temporally, and that's why it's described as a T-SNIT scan or T-SNIT profile. The retinal nerve fibre layer is thicker superiorly and inferiorly, like we'd expect, similar to rim tissue. And the scans, 3 scans taken can be averaged to give a more accurate representation of the average nerve fibre layer thickness. So this is the T-SNP profile, and what the green and red indicate here is the normative database. So the green values are the normal values compared to the normative database. The red is abnormal, and we can see the scan for this patient falls in the abnormal region, nasally, and is normal everywhere else. And 3 scans have been used in this to generate this image. One of the things I find very useful, particularly if you've got patients with asymmetric glaucoma, is compare the T-SNP profile to the fellow eye. Okay, because the profile is so variable, even in healthy eyes. Okay, so if you do a scan of my eye and do a scan of Saad's eye, although we both might have healthy nerve fibre layer, our thickness values will probably be quite different, and our T-SNP profile will be quite different. But between 2 eyes of the same individual, the profile is quite equally matched. So if you've got an abnormal one eye, you're likely to see loss compared to the other eye. So the fellow eye is the best control, if it's normal, for any glaucoma patient. So, the ability of the T-SNP profile to filter out abnormal values depends on the centration of the circle on the nerve. The newer OCT devices, like the Spectralis, have an eye tracking software, which means that as a patient moves his eye, the image moves as well, so that it stays tracked on the optic nerve, so that reduces the variability. The advent of Fourier domain OCT has revolutionized our ability to delineate the layers of the retina compared to the Stratus OCT3, and now we're able to distinguish individual layers, including in a plexiform layer. And it's able to do this because there's no reference mirror in the Fourier domain OCT. The earlier machines had a mirror which moved back and forth, and the resolution of the device was dependent on the speed of the mirror. So the Fourier domain OCT has no mirror, and the signal is analyzed by a Fourier analysis, and it's able to filter out the different layers. Just a little about the cost. These are maybe 2 or 3 years old, but you can see the Spectralis device is about £100,000, and compared to the Cirrus and the OptiView, which are between £60,000 and £70,000, they're much more expensive than HRT. So OCT is taking over, but it is more expensive than the other scanning devices. And of course, a lot of independent practices are unable to afford the OCT and still have HRT. Now, one final point I'd just like to make is, if a report tells you that something is abnormal, whether the patient has glaucoma is your judgment. Okay, it's not the machine's judgment. So if you have a look at a patient, they're low risk for glaucoma, they have normal pressure, they have a healthy nerve, and the OCT is abnormal, then that doesn't give much weight to your decision. But if the OCT findings corroborate with your clinical findings, then you'll place more weight on it. So this is the idea of having a pre-test probability. Okay, when you examine your patient, you assess the optic nerve, you have an idea what in glaucoma is all about probabilities. How likely is this patient to have glaucoma? There is no one test which will tell you in early disease that a patient has glaucoma. It's a clinical decision. So these devices that provide you with some information that you should combine with other information in your clinical exam to figure out your management. One of the most important things to do in your clinical assessment is say, well, how do these changes correspond to the visual field? And we know there's a well-established relationship between the structural assessment of the optic nerve head and the visual field. And this is, the Garway-Heath map, which shows the correspondence between the 24-2 locations in the visual field with optic disc sectors. So when you're looking at a patient, if the visual field doesn't fit with your clinical assessment of rim thinning in a given sector, then you'll be less likely to take that as reliable, and you might want to repeat that visual field. And again, what I said about integrating information, so from your history you're formulating how likely is this patient to have glaucoma, what's the risk profile for this patient to have glaucoma, and that will depend on the age, the race, corneal thickness, and the presence of any family history. And then with your clinical findings, you're estimating the pre-test probability of glaucoma. And the result of your investigation will change that pre-test probability. But what's important is that you have that pre-test probability before you look at the tests. Okay, and here we do, the OCTs even before we see the patient. But just think of it, you wouldn't do an MRI scan unless you have a clinical suspicion of there's something being wrong. So if you do an MRI scan, whole body MRI scan, you'll find some abnormality in a patient, right? So if you see, if you scan regardless, you'll find something, but you should have an idea of what the pretest probability is before you assess your test findings. Okay, thank you very much.